on behalf of the COVID Action Collaborative, I invite you all to today's dialogue on gender-based violence. Thank you very much for being here with us. Today is actually the first of a three-part series, and the series is being led by our partner SNEHA in collaboration with Catalyst Management Services and Swasthi. SNEHA runs a program on prevention of violence against women and children. CMS and Swasthi have over 45 years of collective experience in the social sector, and gender-based violence is one of the core areas that they focus on. Now, the COVID Action Collaborative will be, we've all been together for the past year, and we believe in new world resilience now, because it is a new world, right? All of us have seen that, and so much has changed in the past year during the pandemic. And then when we talk about the gender-based violence at this time, we all know that there has been an alarming increase in cases of GBV. So to start off with today, Shaonli Chakraborty from CMS will present the results of a GBV survey that we had undertaken with the COVID Action Collaborative partners. This new world that I've been talking about, it also presents new opportunities and opportunities for building resilience. And Dr. Nayreen Daruwalla from SNEHA will take us through their experiences and learnings on the issue, and will touch upon the various services provided by SNEHA during the pandemic. There have been partners who are keen to learn more about how they could possibly integrate prevention of gender-based violence into their own programs. And that is the purpose of this series, because at the session today, Nayreen will also draw a thread into the coming 2 sessions that we're going to have, where SNEHA will be sharing how they can help organizations who would like to integrate primary prevention and secondary prevention into their initiatives. We are, after all, a collaborative, and what better way to use this power of each other's expertise than to share, to learn, to grow, and to scale. During the 2 presentations, if anyone has any questions or comments, please do type them into the Q&A. We will keep some time aside at the end for dialogue. My colleague Ambika will also be helping me curate these questions. So then, without further ado, it is my pleasure to yield the stage to Shaonli to share her insights from the GBV survey. Shaonli, over to you.
Thank you, Siddhi, and hello, everyone. A very warm welcome to all of you from the COVID Action Collaborative and Catalyst Management Services. Just before I start, getting into the details, like Siddhi said, currently, our goal from COVID Action Collaborative is to see that how complex problems, which through the pandemic has become more and more complex in nature, and how vulnerable communities are more and more affected, is being addressed through this collaborative effort. And as you all know, gender-based violence, and particularly within gender-based violence, violence against women and girls, is said to be a global pandemic by World Bank, and 1 out of 3 women in the world is affected by gender-based violence. Having said that, as a collaborative, we were wondering that how this pandemic, which is caused by COVID-19, has kind of more worsened the situation, and what is our all our COVID Action collaborative partners are doing at this point of time. So to do that, we just conducted a survey, and through that we wanted to understand that what is the situation on ground, how the partners are responding. And just to also let you know, as of today, as we complete 1 year of the collaborative, we are 310 organizations which has come together, out of which around 73 organizations participated in this process. So I'm going to share my screen and just walk you through the details of some of the responses that our partners have shared with us. Yeah. So I have already, in fact, shared this particular slide. As we all know that the impact of COVID is very deep and very wide and long-term impacts are there because of COVID, and we all are, as we speak, are experiencing it, and in fact, a new wave has come in. So in this particular situation, when we looked at the different vulnerable communities, we also identified that the victims or survivors of gender-based violence is one of the key vulnerable community that that needs to be focused on. To do that, what we, as we said earlier, we asked some of our partners that what exactly, who are the key communities that they work with. And interestingly, many of them said actually they're working with sexual minority communities, which is quite heartening to note, followed by female sex workers, then poor migrants, women in distress, and also people with special abilities. Yeah. So these are some of the key communities that our CAC partners are working with, out of which when we asked that are they involved in GBV prevention and response, again, that was very heartening to note that around 63% of the partners did say that they are working on this space, right? And let me know if you can see the screen. I'm sorry, I didn't check that. Ambika, can you just give me a heads up before I move in?
Yes, we can, Shaonli.
We can. Okay. All right. Yeah. What we also wanted to understand is that how is the pandemic kind of, affecting the, already the global epidemic or the pandemic, which is GBV related. And what we saw that in the lockdown, people has experienced a rise in gender-based violence cases. And they also have seen a rise in the reporting of such cases, right? So these two were worryingly, there, but at the same time, it just validated what we already were hearing from the media reports, right? And also that, when we wanted to understand that where are those situations, key areas where gender-based violence has occurred, and our CAC partners had to address those situations, right? So it is what commonly we have come across is home and workplace, both are common areas where GBV has taken place or has been reported. Followed by, interestingly, if you look at singularly workplace and then home as two key important areas, right? Also, there are places in transit, but the percentage is very less. And I think also that because at this point of time, when we look at the pandemic times, transit is very restricted, mobility is very restricted. So we were expecting certainly that, although we know that migrants, I believe also has, experienced violence during the transit as well. So when we wanted to understand that how then the situation was addressed, and there were a couple of key situations. One is by managing the situation by themselves, the survivors, how they managed it, or how we have kind of, somebody from their home or their family, and they have reached out to them, or they have reached out to police, or they have called a helpline. But the majority of them have either or used one of these situations. However, if you look at, interestingly, there is a tie between that people have tried managing the situation themselves, or they have tried to reach out to police. These are the two most commonly adopted approach that the survivors have taken. Then I think this is where probably Nayreen and team will need to kind of focus on that. what we understood that mental health issues is one of the underlying phenomena when survivors reported the instances of GBVs. Almost 45% actually said yes to that, right? And given that there are still restrictions, but especially during the lockdown, we wanted to understand that how what kind of channels has been adopted by those who had been experiencing a GBV, right? And the most common, of course, has been police, going to police or reach out to the helplines. Yeah. Interestingly, also one-stop crisis centers were also informed, and that's quite heartening to see. But many of them adopted a multiple ways of kind of approaching. This is an observation, remind you that our partners related to when they were, trying to address GBVs, that how the survivors were adopting some of these approaches, right? What we understood from especially the CBOs and NGOs, that what are the kind of barriers they experienced to address the situation in hand, especially again during the COVID period, during the lockdown. And one of the, of course, the common reason or the barrier is the lack of mobility. Many of them say transportation, communication, and restrictions to move around, right? And that had restricted visibility, that had restricted monitoring and counseling support. There's also the fear, and stigma to report, and thereby the delay in reporting, right? So that has also affected, and acted as a key barrier. Also that, as you, you must have observed that one of the common approach was to, reach out to police, but also there was delayed response from the police as one of the barriers that were reported. And as I said, restrictions to a lot of communication and monitoring support that the NGOs has been experiencing. So lastly, when we wanted to know that what kind of support or interventions will make their work, all our CAC NGO partners' work to address GBV more effective, I think the topmost, again, I think everyone will be already aware of that knowledge and awareness, features as the topmost need area. Followed by advocacy and legal literacy, especially on the specific acts on redressal, and then legal advice, life skills for the NGOs and their volunteers and staffs. And resource mobilization or resource funding is one of the key areas of requirement. Special projects also came up as a key need that should be focused on preventing and redressing GBV. Also that, related to that is very critical, the immediate shelter, crisis response mechanisms, rehabilitation of the survivors, and especially, empowering them economically through income generation activities. And lastly, community institution building or strengthening. These are some of the key areas of intervention or support that, our NGO partners mentioned in the survey. So along with that, I'll just stop sharing my screen and I can take some, if there is any questions or comments, I can take it forward from here. Thank you.
Shaonli, we'll wait for the question answer session after we finish going back to Nayreen. So thank you so much. Thank you so much for sharing this, and thank you to all the partners, of course, who had participated in this survey. I mean, clearly, what Shaonli has shared with us, as we were talking about, it just shows the increase in the GBV in the work and home spaces particularly. And it is interesting to find that there are quite a few people who also try to address it by themselves, but then also are able to reach out to the police. And one of the other things that I thought was quite important, given the context of the pandemic, that helplines have become an important mechanism for redressal. Naireen, I'm sure you would also probably connecting very much to this information being shared by Shauli based on your own experiences in the field. Naireen, could you please come and share what these experiences and learnings during the pandemic have been?
Sure. Sure, Siddhi. Thank you very much. And good afternoon to everyone in the group. I am feeling very happy and privileged that COVID Action Collaborative has given this opportunity to SNEHA and to us to talk about our work on gender-based violence. So I am going to show you a very few slides and some data and going to share our experiences of handling violence, mainly in COVID time. Of course, we've been doing this work for years, but in COVID time, how violence came across as such a big public health disaster. And I think because government and for years, civil society organizations have really tried to bring the agenda of gender-based violence in the foray. Because what happens is when you talk about any public health issue, gender-based violence always goes as a back burner. But I think COVID times really showed people how gender-based violence is very important and its addressal is most important. So I'm going to share my screen and show you a PowerPoint that will, yeah. Give me 1 minute, huh? Yeah. So, as I mentioned, we have been working on issues of violence against women and children for years, for 20 years. Now, I think to begin with, it would be important to understand all these terms. So, sometimes we say gender based violence, sometimes we say violence against women, sometimes we say violence against women and girls. So, I think it is very important to understand the terminology. And if we talk about gender based violence, then definitely gender based violence includes any kind of violence that is happening on account of the person's gender. That is very important. So then, in that question arises that if we say gender-based violence, then do we also include men? Because it is possible that violence can happen with men also. But across the world, if you see the statistics, with men, the rates of violence are minimal. They're absolutely minimal. So when we say that on account of gender, or when we say gender-based violence, it also means that violence is interacting at the intersection of gender. And that is important to remember when we talk about GBV intervention. And yeah.
Sorry to interrupt you, but your screen is not on presentation mode. So
Yeah, I will do it because I'm just talking to the. I'll do it. Yeah. And the other thing I wanted to also say, like I was looking at the survey results, and the survey results, there are many organizations working with women in different kinds of occupations, and women doing different things, women coming from different backgrounds. And when we talk about GBV, it is important to understand that GBV, the nature of GBV and the forms of GBV are not very different. Whether it is a sex worker or whether she is a woman, on account she identifies herself as a woman from alternate sexuality, anything, it doesn't matter as long as a woman faces violence. It is gender based violence, and gender based violence includes three main forms of violence. One is domestic violence, which is very prevalent, very, very prevalent across. second is intimate partner violence, and third is sexual violence by non-intimate partners. These are these are the various forms of violence which fall under the umbrella of GBV. Now, someone can say, what about trafficking? Trafficking also is a form of violence. It's the type of violence that falls under the umbrella of GBV. And there is a misconception that intervention for these varied kinds of women are very different. In our experience, interventions for these women are not really different. Because, for example, if you take a sex worker may be facing violence from her intimate partner, she may be facing violence from her client, she may be facing a lot of violence from the police. And you take in comparison to that, you can take another woman who is a homemaker and who is undergoing violence. She may be undergoing intimate partner and domestic violence, but at the same time, who knows? She may be undergoing some or the other form of community pressure or police violence. So, what point I want to drive in here is that I think all of us should not look at GBV intervention in isolation with the constituencies. They are all put together. At the most, intervention can differ a bit in some ways, but the general principles of intervening on gender-based violence do not differ. So this is just a picture of one of our women's groups happening in Mumbai. And it's a lovely picture, and that is why this is our entire program on prevention of violence against women and children. Again, why are we not using gender-based violence, and why are we using this terminology? I think we are using this terminology because our work has been very focused on these women, that is why, but this also is a part of gender-based violence. So, when we talk about gender-based violence, there are globally, if you see the research and if you see programs across India globally, there are three main principles on which GBV interventions are carried out. The first one is primary prevention, and this all came about because the women's movement started in about 1960s. In India, it started around 1960s, 70s. And initially in the women's movement, and not only in India, in other countries, it started a bit earlier. And how did it start? Because in the neighborhood, women used to get violated, and other women staying in the neighborhood used to help them out, get out of the house, or help them go to the police. And this is how the first wave of intervention came in, which was that women require counseling services, women require unconditional support to come out of violent relationships. Or if it is a public violence, then women need help from the police and from the public system to be able to really ask for assistance and help to stop violence. Then a second wave of intervention came in, which was around 80s, and that was about the whole language, the whole narrative change. And the narrative change, and organizations, funding agencies started talking about how prevention is very important. Why do we wait till the woman gets violated? Why aren't we do prevention? Why aren't we do activities in the community, wherever, through media, in different ways, so that everyone knows in the society that violence is wrong and a woman can ask for help? That was the second wave in intervention on GBV. And the tertiary prevention mainly came about later, much later, when it was understood by public health authorities that a woman who comes to a public hospital, and generally if you see all research talks about how when a woman is violated, whether it is sexual violence or any other form of violence, she'll definitely go to the public hospital. And the reason she goes to the public hospital is, one, it is easy for her to give that pretext at home and have her own coping and escape to a public hospital. Second, public hospital is a place where at least if she has injuries or any kind of health issues, then they get addressed. So the whole point came about that along with primary and secondary, it is very important to do tertiary intervention, which will minimize the impact of violence over a period of time. Secondary intervention will stop violence. And if the woman comes and says, I want to do this, I want to leave my home, or I want to go back to my home, then the secondary prevention is a bit limited, where institutions or organizations help in whatever she wants to do. But the tertiary prevention, the public health terminology talks about tertiary prevention as a method of minimizing the impact of violence and restoring mental health and well-being. Tertiary prevention also includes legal issues on how, when a woman is ready to file a legal intervention, how can an organization or how can even the public system help her to file a legal case. So here I want to just show you some of our data in COVID. I made a comparison here of pre-COVID and COVID period. And this is very, very interesting because in the COVID period, there was a surge of domestic violence cases everywhere. But running a domestic violence center and a counseling center for so many years, I think I can very safely say that we have registered 14,000 cases in our counseling centers from 2001 till date. And out of these 14,000 cases, we regularly do analysis. 80% of the cases have always been domestic violence and intimate partner violence. And it is something to really think about. And when I say domestic violence, intimate partner violence, it includes women with disability, it includes women with alternate sexuality, it includes women with different occupations, sex work. So all these women in these 20 years that we have seen cases, maximum we have seen is domestic violence and intimate partner violence. And also, in the last 1.5 years, SNEHA has been running a one-stop center in Mumbai in one of the large public hospitals. Now, the whole objective of the one-stop center was to provide help or to provide relief for women undergoing sexual violence. Of course, OSC guidelines were later on revised to also include domestic violence, intimate partner violence, and other forms of violence like trafficked women, missing girls, early marriage. But again, in 1.5 years that we have run the one-stop center, we see the same trend. And the trend we see again over there is maximum 80 to 85% of women who come to the one-stop center, they come nevertheless. Sometimes they come at night, morning, but they are cases of domestic and intimate partner violence. So what I want to state here is that intimate partner and domestic violence are the most pervasive forms of violence, and these do not really come out in the forefront as easily as cases of sexual violence. If you see why, and the reason is, for sexual violence, generally what happens is that you will read in the media or you will find cases which are really severe. In domestic violence, intimate partner violence cases, you may not find them to be very severe. You may find that violence is going on, dragging on, and the woman is just coping the best way she can. So the difference is this. The main difference is one, this is the difference that domestic violence and intimate partner violence, one, women have learned to face it over the years. Second, is it is considered, why women have learned to face it, because it is considered a very private matter. So women don't want to really come out and talk about it. When they go to the police also says the same thing. ये तुम्हारे घर का मामला है. It is your family matter. We cannot intervene. So I think that has been a big impediment for women to really ask for help. Now coming to this data, you can see over here that in the COVID period, which we have considered from March to August 2020, which was really difficult period because of the lockdown and all, you can see that there has been an increase in cases of domestic violence and intimate partner violence. But again, I think what happened in COVID was, as I'm reiterating the same thing, the domestic violence, intimate partner violence, even sexual violence to a large extent exists. It's only that in COVID period, it became impossible for women to tolerate it. Earlier on, women were tolerating. They had another coping mechanism. They would get some time on their own when husbands go out or family goes out. The lockdown made this very difficult. One, there was increased responsibility on the woman because everything fell on her. And second was that they were in close proximity with the perpetrators all the time. So that led to an increase in reporting of violence because the threshold where women could bear it was absolutely broken down. And on most of our cases in this period of time have been where women have said, I can't tolerate it anymore. I want to just get out of this house, do anything but take me out of this house. And most of the cases were of domestic violence by matrimonial home and by natal home. Natal home also, we had many young girls reporting violence. And of course, intimate partner violence is very much linked to economic resources, husband not wanting to give any money despite of having money. So these were issues that really emerged in the COVID period. And suddenly, the National Commission also saw a big rise in cases everywhere. Everywhere we saw a big rise in cases in reporting, not in actual domestic violence or in actual intimate partner violence existing in the community. If you see the NFHS data, the NFHS data says that 37% of women ever in their lives have faced one or the other form of violence. But at the same time, the data also says that only 2% of women have asked for help. Now, this is a very clear evidence, even for us. If we do not do any prevention activities, we will never have so many women coming to our counseling centers. So earlier on, when we did not do too many prevention activities, we used to get absolute severe cases of injury, burns. So, women took time and women came for help only and only when it was absolutely unmanageable for them. Now we don't see that. In the last 10 years, we see a different trend. We see that women come to us when relationships are dysfunctional, violence is happening, and they want to make the relationship better. So that is a major shift that we have seen. And the shift is because of primary prevention activities in the community one. And because I think now there is a little bit of more talk about laws, TWDBA, 498A. Although 498A is very contentious, yet again women know that there is something for them. So I think these are the reasons why this shift has happened. Sexual violence by non-intimate partner, 38-36, which is a marginal decrease. And as I said, sexual violence in any case, we in these so many years we haven't had so many. Child sexual abuse reported was higher in COVID period. Child neglect was higher, and this was reported by children. And when I say children, they are below 18 years of age, but they have found ways to report it. But here, the last one you can see is mental health issues. And what happened was these women who were constantly facing violence, they came to a breaking point. And the breaking point was absolutely unmanageable anxiety, unmanageable trauma. Women who had undergone trauma earlier also became more vulnerable to more trauma. So this was a stark thing that we saw in COVID period. Mental health and mental health management also was very, very difficult because we were providing our counseling interventions and our crisis interventions on the phone. Yeah. So this is our data about community referrals. And if you see, I mean, community referrals is okay because in any case we do a lot of primary prevention work. But I want you to see the helpline number. So before COVID, the helpline number, we had only 2 women in that period who actually contacted us through the helpline. And the helpline was functional. But I think women prefer coming to the counseling center. And there was no lockdown. So there was no urgency or there was no complete breakdown of mental health. And here, if you see, it has gone to 565 cases, which really shows a big, big jump in women asking for help. And COVID situation really made it unmanageable for women to kind of stay in the same home. So we had to do all kinds of intervention through the phone, talking to the police, talking to the CWC members and other members to see where we could help the woman. One interesting finding in the survey was that in this period, organizations helped women by exploiting support networks. And I think that is very true, not only for organizations, even we as an organization who have protocols and everything on dealing with such cases. In COVID period, we had to rely a lot on our exploiting support networks that would really help women to get out of these difficult situations. Now, in COVID times, if you see the data, we essentially work in urban informal settlement. But in COVID times, our data, our referral source also changed. And you can see that from Pure, it was 41% of women called up from Pure. And I'm sure all of you are familiar with Pure in Mumbai. I'm sure you see in Bollywood films. And these are not urban informal settlements, these are Pure. But it's a high number of women calling up from these areas. Flat, 27% called up from flats, and again a similar number from Jhopalpatti. And the reason is also in the first 2 months of the COVID period, we got less referrals from the Jhopalpatti, means from the urban slums, because they were consumed with the anxiety and worry about food and subsistence and continuing with the normal life. Lockdown, social distancing was difficult. Food was a big problem for these people. And you can see that at that point of time, the priority shifted from violence to really existing and living and managing in these situations. Women who are never employed, this is a standard year after year. We have seen that this number, this percentage does not undergo a change. So it can vary a bit, 48, 47, but it just doesn't go up. So one of the things also which we have seen is employment. Women not really having the resources and women not being able to really manage with money issues. And that also leads to a lot of economic and emotional violence. Not currently employed, 23%. So, I mean, all these numbers, if you see, they are pretty low. But at the same time, till date, no research has proved that if a woman is employed or if a woman is economically independent, then she doesn't undergo violence. So I think this is one gray area where we need more and more research to understand that women who already are employed and financially independent, they have equally reported different forms of violence. And their forms of violence are a bit different. They are not blatant physical violence, but they are more emotional violence, deprivation. And earlier on also, being in Bombay, we've had cases from the Bollywood, and all these cases, high media profile cases, all these cases were about economic violence and emotional violence. And so it's interesting how forms of violence also undergo change with the constituency and the strata that the woman belongs to. Yeah. So of course, this is the last slide, and then I'm very happy to have questions or talk more about it. So I think in this period, we provided psychosocial interventions to 2,115 women. These women all had contacted us through the helpline. I think what happened was when they called, it was very, very hard for the counselors to provide intervention because the perpetrator is sitting right there. So our counselors had to actually work day and night because the woman will say, I will call you in the night to talk to you. But it was useful. It was useful providing the helpline services because it really helped many, many women. When women required crisis intervention, we called up the police because we have now, after working for so many years, we have developed good ties with the police. So the counselors would call up the police, urge the police to help the woman with the intervention. In the meantime, we rescued many women from matrimonial homes, provided them Ubers and got them to come to natal homes. So these interventions, I think, in COVID period were very, very useful to these women. And as I said, mental health intervention was a big part of our work in the COVID period. And we had to employ an in-house psychiatrist who helped with psychiatric care. Police intervention, we reasonably did quite a bit in COVID time because that was the only source. We had only two sources. One, exploiting the survivors support networks, which we did a lot. And second, police. The courts were shut, the shelters were shut, and nobody was willing to really take women without doing a COVID test and all kinds of things. So the one-stop center was running and all our helplines were running. So yeah, this is my presentation. And so I'm very happy to take questions or.
Thank you very much, Nayreen.
Yeah.
That was such an interesting presentation. So many things to kind of key takeaways from there, particularly about how domestic and intimate partner violence you found to be the predominant form of violence. I think what was also very important and would be very important as we go ahead with this series is that you did share that there has been a shift in talking about violence and asking for help, and this has increased, and primary prevention is something that has really helped that. So that is something I think which is very important for all of us and the partners out here to really understand, and we will talk about that a little bit more. So, but before we go on to that, can I just, I think Shiv has a question. I will just call on him to ask his question.
Yeah.
Shiv?
Hi, Nayreen.
Hello, Shiv. How are you?
Very good. Good to see you. And thank you for sharing the experience. And most importantly, thank you for doing this phenomenal work. We need thousands of SNEHAs around this country to do what you do. All power to you. I had two questions for you, Nayreen. One is, we know the cost of violence to the perpetrator is very low, and to the person who's in the receiving end, I don't want to call them victims, because they are powerful people in a position of power which doesn't allow them to be powerful. And the cost is very low to the perpetrator and very high to the person receiving the violence. And in your view, from a prevention angle, how has this worked? Have you been able to increase the cost in certain ways? That's one question I had.
Yes.
The second question is very interesting point you made, that the economic situation of the woman does not seem to have a correlation to violence.
Yeah.
Goes against everything we all had assumed.
Yeah.
In fact, I remember my mother blessing any girl falling at her feet is be economically independent. That I know she meant it in many ways, and one of them was less violence of all kinds. But this is really striking, Nayreen. And the question I had there was that, is it because that the violence extends to the economic arena too, in terms of capturing the savings and the income, and therefore it doesn't have any impact? Or is it fundamental that the family does not have methods to respect each other's income and have agreed boundaries, whatever be there? Over to you, Nayreen.
Yeah. Thank you, Shiv. So I think your first question is very important, Shiv, and I don't know how well will I answer, but I'll try my best. And that is, yes, when we talk about interventions with men, I think even today, after working for so many years, Shiv, interventions with men are very limited. And the reason for that is, and if I'm allowed to share a bit, in the beginning, we could not mobilize men. And it was considered to be a very woman's issue. And even in our communities, it was considered to be, no, if you are dealing with violence, then you can only work with women. So we formed groups of women, and many, many groups of women in the beginning. But men were like not seen anywhere. Then in 2006, we did an urban micro-planning process, which was proposed by UNICEF. We did those processes, and those processes were involving the community to understand their own needs on what they would like to work on to bring about sustainable development. When we worked on micro-planning, suddenly we had many men volunteers who wanted to come and help. But these men volunteers, again, it became so that we formed Dharavi action committees and we formed Govandi action committees, but they wanted to only do community development. They did not want to do any issues on gender-based violence. And we realized as a program that we are ourselves perpetuating that divide by, giving men the privilege to do sustainable development issues, whereas giving women the whole ambit of doing violence work. And slowly, when our understanding increased, I think over the years, even today, it is very lopsided. Even today, Shiv, I think there is a lot of talk about interventions with men and changing men's behaviors. But in my experience, yes, it is possible, but you need a lot of resources to do this. And what happens with women, if you want to do a gut meeting, if you want to do anything, they're ready to sit anywhere, do a meeting. With men, the prerequisite is they will require a closed place, they will want food and snacks, and they will want their own time when we have to do the meeting. So I think I don't know how far I've answered your question, but in terms of really working with men, I think the change can only happen if organizations decide that they will only focus on men and work with men. Then it can happen. Otherwise, I think it's very difficult to make them bear the burden of violence. Is that good enough, or you want to?
No, I can't agree with you more. Siddhi, if I can just have one supplementary point to Nayreen.
Yeah.
Uh, Nayreen, sometimes I wonder maybe the next generation of boys and men is what our focus should be when it comes to prevention. Not to give up on the current generation, but essentially exactly what you mentioned, that it's going to be a humongously uphill task to change the norm around control, power, behavior, and many types of violence. But the only silver lining I see is daughters of men and boys of men who are violent, right, of various nature. What is the role they can play, and also the next generation? How are we readying them for to be better and more respectful to?
Absolutely, Shiv. And I think we also try and do that. We don't do it enough, Shiv, but we do have men volunteers who are supporting our women volunteers. But the whole process is a bit slower as compared to working with women.
Right.
Yeah. And the second answer is, I think what we have seen in our work is, irrespective of socioeconomic class or irrespective of how economically independent the woman is, what really happens is the norms of controlling behaviors, they are perpetuating violence. So whether it is an affluent family or whether it is a very poor family, these norms are so pervasive, and these norms actually perpetuate violence on women. So this area is still very contentious. All I can say is what I have seen is women who are economically independent, they have one more choice, and that choice is they can get out of the relationship because they are more independent. Whereas women who come from very poor classes, they cannot afford to do that. So they stick to that relationship no matter what happens, they will stick to it. That is the difference we see. But again, with very independent women and very affluent women, they don't want to do it. And the reason is their property and wealth is at stake. So because they are rich and because their husbands are very rich, they don't want to give away that part, and they don't want to get independent because they will lose out on all that which would be their entitlement. So it's very complex.
Thank you, Nayreen. I think it's one thing to say complex, but to continue to work on that area, as I said, more power to you.
Absolutely. Thank you, Shiv. Yeah.
Thanks, Nayreen. If anybody else has questions, if you could just raise your hand, we will unmute you. Don't worry if you can't see your little mic there. I think, does Hemal have something to say? Okay. Shaonli, you'd like to come in for a couple of minutes before we hand it back to Nayreen?
Yeah, no, I was just cognizant of time. I think one of the very interesting programs that in parts of Africa, which has happened, is on parenting and engaging men to address gender-based violence. But I do agree with Nayreen. It has been extremely hard, to engage men to address gender-based violence, and we have seen it in every forums, from community institution building to at the policy making, that it is women who is speaking for for women. It has become like a women's issue, although we all know that gender-based violence is a very cross-cutting phenomena. It affects both women and men. But I think something that I wanted to also share and put it out to Nayreen and all our NGO representatives here is I see that, while we talk about that how critical is to address gender-based violence, as Nayreen has already mentioned, it is not that hard to actually do certain kind of programs or certain kind of efforts. But I see a lot of hesitation between being a very domain specific work that NGOs do to do something which people think it has to be very feminist, right-winged approach to do gender-based violence work. And that is a problem. I feel that is almost like a barrier by itself that we need to address. And how do we kind of address this? Because we talk about ecosystem response, we talk about stakeholder engagement, but somewhere I think we as a sector has not been able to kind of mobilize it within ourselves and influence ourselves much more. So yeah, I'll stop here.
Can I answer that, Shaonli?
Nayreen, if you don't mind, there's one more person who has to ask a question, then you can take both of them together. I am not sure there's not a clear name here. It is a BWDAB. Whoever you are, please do ask your question. We have unmuted you, and please do introduce yourself. Hello.
Hello, ma'am.
Yes, please.
Hello, ma'am.
Yes, we can hear you.
Yeah. This is Fatima from Bauda, Vilpuram, ma'am. Yeah, I am the family counselor. I have one doubt, ma'am. Previous section, you told me prevention of violence against women and children. You said 3 options: primary prevention, secondary prevention, tertiary. That one is long-term process or short-term process, ma'am?
No, it is a long-term process, Fatima. But it's not that you have to do everything together, Fatima. It depends upon the remit of your organization. You can take one part and do it.
You said 3 options, ma'am: primary, secondary, and tertiary.
Yeah.
That one is in the one-stop centers, it will be available.
Yes. But what I'm saying, Fatima, is that not all NGOs have to do everything. You can do one part of the work.
This one is a short-term process. Long-term process means it is not to empower the women at a short term. Okay, it take a long time.
Okay, so I'll tell you. If you provide counseling services, then at least you will start the process of empowering women. Because women who come to you, it takes about, when she comes the first time, it takes about 6 months for you to empower the woman, right?
Yes, sure.
Yeah, but if you want to work in the community, Fatima, it will take a longer time.
Okay, ma'am. Okay. Thank you for my doubt, ma'am. Thank you.
Yeah.
Thank you so much, Fatima.
Thank you, ma'am.
Nayreen, can you just pivot to the next 2 sessions, and then we will go back to what Shaonli's comment?
Yeah. So I think the next 2 sessions, we will be talking about how, for example, if NGOs are working on health, and even if NGOs are working on health, how do we integrate interventions on violence? And I think it is important to understand, and we will discuss in the next session, where we can have an integrated approach rather than thinking that gender-based violence is very hard to do. Then I don't think we'll be ever able to do. But if it is an integrated approach already with the issues that you are dealing with, I think it will be easy to integrate. So the next session will be on how violence can be integrated as a public health issue if you are working on health, how violence can be integrated as a community issue if you are working with as a community-based organization. I think we can explore all these possibilities in the next session. And mainly primary prevention. So the next session, we can focus on primary prevention, which is the backbone of gender-based violence intervention, and how primary prevention integrated into any work will yield gender-based violence interactions with your community. The third session would be on integrating secondary interventions, and those are more specific counseling interventions, interventions to coordinate with the police, with the legal system, would be the third session if any organization is interested in taking up that part of the work. Anything, any question anyone would like to know more, Siddhi?
Thanks, Nayreen. I think what is really important here is that today we've kind of looked at the issue itself and really looked at understanding the issue. And as we go ahead in the next two sessions, what we're really hoping to do is to see how can this understanding move to action on the ground, and particularly for organizations that may not have been working in the area of GBV at all. And I think a lot of us who do not will also be seeing GBV, and there is also a feeling that there is a need for this. So how do you kind of integrate it? So thank you. I think we're done with our time, and I would really like to thank Nayreen and Shaonli for sharing all their experiences with us today. And thank you everybody for participating. Do reach out to us if you are interested in the second and the third session. And as I said, I think it would be very useful in terms of action. So hoping to see many of you all back on the 9th and the 16th of April. Thank you.
Thank you. Thank you.
Bye-bye.
Bye-bye. Thank you.
Bye, everyone. Thank you.
Bye.
Bye.